right. Hello, everyone. My name is Courtney Szymborski, and I'm the manager of value-based care here at Anatomy IT. Today, I'm joined by Renee Fryer, the vice president of value-based care, and we're excited to bring you some important education designed to simplify your understanding of MIPS in dermatology. Whether you're new to MIPS or simply looking to optimize your performance, we will provide key strategies and updates you need to succeed in 2025. A few things I wanted to mention is that all participants are in a listen-only mode. Please put your questions in the chat and we'll monitor those as they come in and answer any questions that we can at the end of the presentation. You will also receive a recording of this webinar sent to the email address you registered within the next couple of days. All right, and then a little bit about us is we have MIPS experts who set you up for success. If you are required to report MIPS, so as we get further into this webinar, keep that in mind since we are covering a lot of information. Our MIPS experts work with over 3,000 clinicians, helping them to avoid penalties and earn bonuses. During this webinar, we hope that you gain an understanding of MIPS and know that we are here to help you succeed if you ever need additional support. So what is merit-based incentive payment systems, or otherwise known as MIPS? It is a program that adjusts how doctors and healthcare providers are paid based on the quality of care provided, efficiency, and use of technology. Depending on your score, you can either get penalized, or if you do well, you can earn a bonus. I'll go into more detail on that in the next few slides. The Quality Payment Program, or QPP, is a program that was established in 2015 by the Medicare Access and Chip Reauthorization Act of 2015, or MACRA for short, which ended the Sustainable Growth Rate Formula, which was directed by CMS to create the Quality Payment Program in 2017. So there are two ways to participate in QPP. One is through the Advanced Alternative Payment Models, also known as Advanced APMs, which requires you to take on more financial risk. Most people are not part of APMs. They are in the MIPS track, which is the fee-for-service track, so that is what we'll be reviewing today. And why does all of this matter? It matters because the score you receive determines whether or not you get a MIPS payment adjustment on your Medicare Part B physician service reimbursements. So if you get 75 points or above, you avoid a penalty. At 75 points, you get no adjustments. So this is the threshold to avoid a penalty. This remained the same last year at 75 points. So below that on a sliding scale, you get a penalty depending on the points you receive, which is up to a 9% penalty. Above 75 points, you get the budget neutral bonus. This is also on a sliding scale. So the better that you do, the more you get. But since it is a budget neutral, the bonus amounts are determined by the penalized providers. One thing I also wanted to note is that CMS has implemented a 5-star rating system for measures, which is published on the Medicare Care Compare site. So something to keep in mind that these ratings are things patients can look at when choosing a new provider. What are the criteria for MIPS? What determines if you need to report under MIPS? You must bill more than $90,000 for Part B covered professional services and see more than 200 Part B patients and provide more than 200 covered professional services to Part B patients. You must meet all 3 criteria to be required to report MIPS. The eligibility is found on the QPP website under participation status. And then scoring under traditional MIPS is scored by the weighted sum of the 4 categories. So quality is worth 30% and cost is also worth 30%. Promoting interoperability, or PI, that is the EHR portion of MIPS and is worth 25% of your score. And the improvement activities is worth 15% of your overall score. So now that I've covered all of those topics, I'm now going to hand it over to Renee to dive a little bit deeper into these categories.
All right, thank you, Courtney. So we are going to cover the MIPS categories and the MIPS value pathway. We're going to start with that. I also want to call out, if you see anything that's highlighted, those are 2025 program changes as we go through. All right, so we're first going to cover MVPs. So for the MVPs or MIPS valued pathway, there is a process to submit via traditional MIPS or the MVP. And traditional MIPS, there's not been any major changes. On the left side, if you see where it says IA and that's in blue, we're going to cover those changes when we get to the improvement activity section. But for the purpose of comparing it to MVPs, it's essentially the same, except the minor adjustments for improvement activity. On the right-hand side for MVPs, in the quality category, you would pick from a limited selection of measures in your MVP. We're going to cover that in a minute to show you some of those measures. They're listed just for 2024 since they haven't fully released the benchmarks for 2025 yet. But it is a much smaller group of measures. This can be good and it can be bad. It depends on like the measures that you would typically qualify for, as well as your volume in those measures. So that, but then also at the same time, having it more limited can simplify it. And then the other thing for MVPs is that you report on 4 measures, and the rule still applies as traditional MIPS. The part right behind it says one must be outcome, or if it's an outcome measure and isn't available, then it trumps, high priority trumps it. So the difference with quality under traditional is you report on 6, whereas MVP you report on 4. Now, even though it says 6 and 4, we do always advise that practices report on well over 6, or in MVP, well over 4. It's just that Medicare will apply your score to the highest 4 scoring measures or highest 6 scoring measures, depending on how you report. But technically, to be able to get the maximum score, you would have to make sure that you do report the 4 or the 6. And then for the population health measures on the right-hand side as well, so there would be a calculation for any population health measures that would apply, and then you apply the highest scoring one. Instead of just selecting one at the registration, it's whichever one is highest. So that is something nice that can be done for MVPs. And then cost, you're scored on any cost measure which you exceed the case minimum if it's included in the MVP. So the reason it specifically calls that statement out, and it's in italics, is there are MVPs that have limited the number of measures or the measure types that are available within it. So we'll cover that when we get to the next slide. The improvement activity change, you report on just one IA measure from the limited selection of IA. So again, similar-ish to quality. In traditional MIPS, you have all of the IA measures you could report on. You choose the one that works best for you, whereas in the MVP measure set, you have a smaller grouping to work with them. Promoting interoperability is exactly the same. The one change, because there is the MVPs for dermatology that should be considered for practices. Want to note that if, say, you submit traditional MIPS and MVP, CMS will apply the higher of the 2 scores. So you may already be familiar with, if you're a group, if you're an individual, all you do is an individual submission. But if you are a group and you've typically done group submission traditionally, if you report individuals as well as group, Medicare will apply the higher of the 2. So it's a similar concept. It's just that it's different reporting models. One is MVP, one is traditional MIPS. But it's great that they do apply the higher of the 2. As far as which route you should go, A, we do discuss these with our clients, but B, we hold off discussing them as far as very specific drilling down for each practices that we work with until after the benchmarking is released. If you see where that mouse was at the very bottom. So between January and February is when CMS releases the quality category benchmarking. Essentially, it just means how each measure is scored, how strict the scoring is. There's lots of details that's included in that, and we have to take some time to digest, process that information, and then be able to update the presentation that we have for MVPs to then be able to give a good analysis for practices. The good thing is that MVPs, you don't actually have to decide until early December. So it's not something that if you decide to go both routes or just one, it's not a Q1 and registration date. It's all the way in December. We would always advise to do it long before then, but I wanted to call that out. All right, so this is the measure list for dermatology MVP. I know there's a lot of colors on the screen, so I just want to call out over on the right side. There's measures that are non-benchmarked, and I want to just point out, look at the volume of measures. So we do not have the benchmarking yet for 2025, as I said. So this is where this particular slide is going to really, really drive us to help inform our practices making their decision on whether they should report through MVP instead of traditional MIPS or in addition to it. But we really need those benchmarks to be available to decide, okay, what measures do you qualify for? How are you scoring? Is the measure benchmarked? Is this measure scored lenient? Do you have subspecialty? Do you just lots of different factors that would play in? And so the ones that are listed as non-benchmark, that's just based off of 2024, but we will be updating this once that's released. So there's a lot of measures, but I also want to call out, if you see on the left-hand side, it has measure names, and you start seeing where it says AAD 6, 8, 12, 16, et cetera. There's a lot of measures that are available through DataDerm, which is the official MIPS registry by the American Academy of Dermatology. That's the official approved one. And that specific registry, DataDerm, is able to report on the AAD measures. No other MIPS registry is able to report on those. And you can see about little bit, almost half of the measures are AAD driven measures. So this is something where if you're a dermatology practice and you're not reporting through DataDerm, this is something that for our existing practices, and if anybody signs up, if you're not using DataDerm, we talk through that. This is the pricing, this is what's included. These are the measures that you could report on that could help you. And again, we would talk through each of those measures to talk through your specific practice's specialty. The one thing that I do want to also call out is the cost measure, melanoma resection. If you typically refer out your melanoma cases, then you just wouldn't be eligible. Or if you typically refer out, but you sometimes treat melanoma cases, we often see many practices who just treat sometimes. They don't even reach the case minimum, which is 10 patients. But then also you may absolutely qualify, and it's well over 10 cases for treating melanoma cases. Mohs surgery excluded, so I want to call that out. So Mohs surgery CPT codes specifically are excluded from the measure. But the one good thing is that the total per capita cost measure, or also referred to as TPCC, that measure is not included in the cost grouping for the MVP. So if you have NPs or PAs and they bill out under their own NPI, then you typically are going to be subject to being scored on that TPCC measure. And the scoring is completely out of your control. It's based off of all Medicare Part A and B services provided by Medicare providers, not just your practice or your specific mid-level clinicians. So this way, if you do typically get scored and say you don't normally score well, then this could be an avenue where you would want to consider MVP only or try for traditional and MVP. The one thing to also keep in mind is, say you typically don't score well in melanoma, but you do in TPCC. So TPCC helps to balance because it brings the score up. You probably definitely want to report traditional MIPS because you do want that total per capita cost measure to help increase your total score. We'll cover that when we get to the cost category section though, but again, I know this was a lot of information, but you can see we take a lot of depth to cover this with our clients. And then the last slide for this is just showing the transition from traditional MIPS to MVP, showing from 2022 through 2026. I just want to call out that top box on the right. where CMS requested feedback on setting 2028 as the last year of traditional MIPS, which would make MVPs mandatory in 2029. As you can see, though, from the previous slide, there are a lot of measures that are not benchmarked. And so it's hard to, you can't predict what that score is going to be until a few months after submission. So it can make it very challenging. Also, for those who have been following MIPS and understanding it as years goes by, it seems like each year we keep losing one or two derm measures, but we're not gaining that many, or the ones we gain don't really work with an existing clinical workflow. So there's that element too. So by 2029, what will that really look like? There's absolutely a possibility there could be enough public commenting to where they push that beyond 2029 and reconsider what measures are included within the MVP program. So I just don't want to alarm anybody, but at least that is still several years away. All right, next we're going to talk about the quality category. This is a full year performance period. You earn up to 60 points, and it's weighted at a specific amount that Courtney had showed in an earlier slide, but the category weight is based out of 60 points. And then, as I mentioned earlier, when comparing MVPs, you submit at least 6 quality measures. One must be an outcome measure or a high priority, but an outcome measure trumps high priority. If you're an existing customer of ours, this may be new to you, or even if you're not an existing customer yet and you're like, I'm not really sure what this is, we look at the outcome and high priority, and we take that into consideration with what measures we choose to report on for our clients, and often this can increase a score. We've seen this for many practices each year. So this is something that if you do manage MIPS yourself or don't work with us, that's something you're going to want to make sure to research. And then quality at a base level, if there's all categories being reported on, it's weighted at 30% of your MIPS score. And then over on the right side for bonus points, there's 6 bonus points for a small practice when you have 15 or fewer clinicians. And then you can receive up to 6 points for improving on a measure from the year prior. And then you don't find this out until when the scores are released, and the scores are typically released in late July, early August. So that's when you'd be able to find out. However, you're going to know if you improved on a measure from the year before. You know that just because you can look at a previous year and you scored 82%, and this year you scored 97. So you know there will be an improvement. It's just TBD on what that actual score will look like. But at least you would know that some additional points would be coming. And then you can report through a registry, a qualified clinical data registry. CMS loves their acronyms, or it's also referred to as a QCDR. I mentioned it earlier when I brought up DataDerm. So DataDerm, who houses those AAD measures that I was showing in the MVP, that is considered a QCDR registry. And then claims for small practices only. We very much advise our practices to not report through claims. It's getting increasingly difficult and almost impossible at this point to not get a penalty. Typically, though, if you're doing claims reporting, oftentimes you may be on paper. So we've also heard practices say, well, we are saving costs by not paying for an EHR. So even if we get a negative payment adjustment, it's worth it. So, but we just see that very, very much more limited. But that's typically the reason if we hear practices say that. The one thing I do want to call out is that small practices only. We have seen some practices who didn't, like, the claim codes were getting accepted to CMS, they weren't getting rejected. But if you were considered a large practice in the eyes of CMS, then you aren't going to be able to report on this particular category. You'll think that you're reporting on it, but you won't get scored. And we have seen some practices who started working with us, and when we did analysis on data that was submitted historically, and some were like just recently submitted, maybe like 2 weeks earlier, or they had gone halfway through the year and were doing claim submission, for example, that unfortunately they wouldn't get a score in the quality category. So that's why we wanted to specifically call out that it's for just small practices. And then for scoring, so on the left-hand side, you've got general measure scoring. So it's anywhere from 1 to 10 points for a measure when there's a benchmark, meets case minimum, and data completeness. And if you are an existing customer or an upcoming customer, we can explain and simplify what all of those things mean. It would be too much to explain it in this presentation because I know also it's just a lot of jargon and it would just be a lot of information thrown in a limited time. So for data completeness, the reason this says 75% is you just need at least 75% of your data attested for each measure that it comes from the EHR. This number used to be much smaller, but it's now at 75%. Before I talk about small practices, on the top right, if you see data completeness, it was going to be 75% preserved through 2026. And the final rule, they updated it and said they're preserving 75% through 2028. That could mean in 2029, for example, they're going to require 80%, 85%. The practices most impacted by this are the ones where the group is in the EHR, but maybe 2 or 3 clinicians are on paper, as just an example. That's typically what we see. There's many other scenarios, but that can be a common one that may allow you to not hit those numbers. And then back on the left-hand side, for small practices, which is 15 or fewer clinicians, you would get scored for 3 points for a measure that doesn't meet the above criteria. There's 3 indented bullet points. We are able to, in the program we use, are able to identify this, and we let our practices know. And then large practices, if you have 16 or more clinicians, unfortunately, you do just get 0 points for the measure. But if a measure were to get a live benchmark, and that would require enough practices and enough patients for those practices to report on the measure, and say the large practice is scoring perfect, or the small practice is scoring perfect, and they're only getting 3 points for small, 0 for large. If that measure for that year were to receive a live benchmark, and they receive the benchmarking based on data from that current performance year, the practice could actually go for that measure from 0 to 10 points or 3 to 10 points. So we have seen considerable score jumps. The issue and some of our frustration with the high volume of non-benchmark measures is the unpredictability of it, especially if you report on many. But at the same time, we have seen practice scores go up significantly as a result. So we do advise to report on as many as possible, even if the score looks disappointing starting out at the time of submission. And then over on the right side, for measure scoring for new measures, this is a maintenance of an implementation they added a couple of years ago in the MIPS program. So for a measure that is brand new to the MIPS program, as an incentive for practices to report on these new measures and ideally be able to establish benchmarks. So that way you're not getting those 0s and 3s, as I mentioned. They're incentivizing practices by simply reporting on it, you get an automatic 7 points. You can score up to 10 if those measures get a live benchmark that I just described before. So say you're scoring perfect, you would get a 7 by default, but you could actually score up to 10 points for those measures. And then a measure where it's in the second year of the MIPS program, it's 5 points. So again, if it gets live benchmark and say you're scoring perfect, you can go from 5 to 10 points, or at a minimum, you're at 5. You're never going to be below 5 for the second year, and you'll never be below 7 for the first year. And then overall, just 2025 measure changes. There's 7 new measures, 66 existing measures with substantive changes, and then a removal of 10 measures. So specific for dermatology and plastic surgery. Measure 137, the melanoma recall measure, we fought this one for years and years, and they kept preserving it, but unfortunately, they officially removed it for 2025. It was up on the chopping block to get removed for 3 years, so at least our commenting did help play a role in maintaining this measure, particularly since melanoma is one of the highest risk diagnoses that dermatologists treat. Unfortunately, they did remove it. This was typically a measure that we see practices scoring perfect in. Now, they did replace it, or they say it's duplicative. And it says it's measure 509, melanoma tracking and evaluation of recurrence. While it is another melanoma measure, the workflow and implementation is where the issue comes in. It is a very, very strict scoring measure and would typically yield a decent patient volume if you've been in your EHR for years. If you treat melanoma cases and perform procedures on them, you would need to be not just refer out, so you would need to be treating melanoma. So this is where you might have qualified for melanoma recall because you perform skin checks, whereas you may not treat melanoma, therefore you just lost a measure and didn't gain a new one. So there's that element. The other part they're looking for is the AJCC staging to be formally documented. And this isn't documented on a path report. This is specifically like in a field within the EHR. We often have seen that practices have had to add fields to track it because we often heard, oh yeah, it's in the path report. Well, it's a PDF document. They're not able to just automatically pull data from a PDF. It has to be a structured field. So because of all of these things, this is where we've often seen an issue with this particular measure. Now, it does say that it's a new measure, because I just want to jump down kind of from top to bottom. If you see that measure that I was just talking about is the 509 melanoma tracking. So it is technically a new measure, which is great in the sense that you will get 7 points if you at least have one patient in the denominator. So that's the rule, that new measure rule. So you'll at least get 7 points for this year. That won't help you in a couple years when the measure will be scoring 1 to 10 points, but at least for this year. And next year, you'll be getting 5 points. This measure technically isn't new, though. It was available in the DataDerm registry for the past couple of years. This is why we have some of this analysis that I just shared available based on our practices that use DataDerm. The difference, the reason why it's new is it's no longer a QCDR measure or an AAD measure. It's now officially a CQN measure. So it's an existing measure that other registries outside of DataDerm can report on. So it's great in that you'll get 7 points, but obviously maybe not long term. It would be ideal if some of the measure parameters were to update. So that is something that we can hope for and try to push to have some measure changes as far as what's included. And then the next measure is 170, jumping back up to the top, measure 176. This is tuberculosis screening prior to the first course of biologic or immune response modifier, very lengthy measure name. And what they did was they added a new biosimilar medication to the denominator, and CMS is going to release that information sometime in December 2024. It has not been released yet. And then for measures 485 and 486, these measures are very similar. One is for psoriasis, the other for dermatitis, and they're looking for an improvement in patient-reported itch severity. Both measures have finalized changes that are the same. So they clarified the denominator, the initial encounter. So what they're looking for is the patient-reported itch severity at each encounter. And then say the patient is seen 3 times in the performance year. The very first encounter in the year, even if the patient has been seen for psoriasis or dermatitis the past 3 years and they had multiple visits, what they look at is the initial encounter in the performance period is like their initial index as far as their severity, their patient reported severity score for the itch severity. And then in that indented bullet point, it says each visit after that index or initial 2025 visit will be considered a follow-up visit to determine the outcome of the measure. So big picture, you need to document this at all encounters if this is a measure that you're wanting to track to be able to score well in, especially it's kind of a 2-in-1 if you treat dermatitis and psoriasis and you just, this is one area, one field to document, and then you'd be able to get credit whenever either of those diagnoses apply, but it would at least have like the same model and process as far as using an itch severity scale. And then we already reviewed measure 509, that it is a new CQM measure, and I discussed the AJCC staging documentation. Then last, we've got general measure updates. So on the left-hand side, there were 14 general measure changes. We do have a MIPS 2025 final rule changes report for details that we'll go ahead and post in the chat. It's also included in our blog. So if you look at our 2025 blog, which covers the top changes, which we'll also put in chat, towards the top of the blog, there's a link that brings you to that changes report. And then over on the right-hand side, there's several measures that have some updates, and these are things that we'll be able to review with our practices. So again, if you're not an existing client and you want to go through those details, how they impact you, we'll be able to discuss that on your 2025 kickoff call. So there are some changes to measure 130, documentation of meds. We do see this measure often documented. And then measure 155, falls plan of care. That one has been removed, but specifically just for claims. I talked about that way earlier. It can be really challenging to report through claims. And it's always best to report through either an EHR or a separate registry like Dataderm. And then measure 238 had some slight modifications for use of high-risk meds. This is another common measure we see. Some other additional clarifications for 374, closing the referral loop. We also see this as a common measure to report on. And then just called out measure 508, especially because it's a new measure, not necessarily because dermatologists are documenting or tracking COVID vaccination status, but it's 7 points. So there's that. That's specifically why we wanted to highlight that here. All right, next we're going to cover the promoting interoperability category. So for the PI basics, this category is 180-day consecutive day reporting minimum. It requires ONC certification in order to report on the measure. Depending on the EHR or the registry that you use, some registries or if it's an EHR, they just have your ID, the ONC ID for the EHR just built into the submission. But registries like Dataderm, for example, you would need to enter in that specific ID, which is also referred to as a CERT ID. So if anybody's used Dataderm, you see the CERT ID. This is something that we do the analysis and pull this data for our practices to make sure that we're able to generate that ID. So that's required in order to report on PI. And then this one is based out of up to 100 points, but technically you can get up to 105 points. And there's a couple of bonus options available. The easiest example that we like to give is if you use the Dataderm registry as a QCDR, which is a QCDR, then you're eligible for 5 bonus points just by simply using the Dataderm registry. And then over on the right side, there's the qualifying submission for PI must include the following. So there's attestation measure statements where yes is required or an exclusion if that's available. And then performance rate measures. There has to be at least a numerator of 1. If your denominator is, say, 45 and your numerator is 1, you're not going to score the best, but at least you're not going to score 0. That's the key, is that if you don't hit all these marks with the attestations of yes or exclusion, at least numerator, CERT ID, all of these requirements for every single measure, even if you score perfect for 98% of the measures, you would still get a 0 in PI. So it's very much all or nothing as far as making sure that you're completing everything for the measures. And this is something for our practices that report on this category or report on this category even if they're not required, to help boost their score. If they're not scoring well in the quality category, it can help offset some points, where we sometimes advise our dermatology practices to report on this particular category, and we go through and monitor this for you and provide updates after analyzing the PI reports. And then, as I mentioned before, you also need that CERT ID that I described, where it's that EHR ID to make sure they're in compliance with current standards. And then also the start and end date for the performance, which I mentioned has to be at least 180 days. PI is weighted at 25% of your score. Small practices are still eligible for a small practice hardship exclusion, which is automatic. So if you have fewer than 16 clinicians, you will receive that automatic reweight. But as I just mentioned, we sometimes do advise our small practices, particularly dermatology, to consider reporting on this measure based on how other MIPS categories are scoring. And that's something that we review on our kickoff call and can assess throughout the year. And then this is a big win. So starting in 2024, it may not impact you much, but to us, it feels like a big win because we have seen some practices impacted by this. So clinicians and groups with multiple PI submissions will be assigned the highest of the PI category scores rather than a 0. So basically, if you do a submission for PI and then another submission, if you did it for quality, IA, it wouldn't cancel itself out. PI did. It would cancel it out and set PI to 0 points. We have seen some practices that unfortunately were impacted by this, whether it was an existing client and they went ahead and did the submission themselves instead of us doing it, or a new practice where we were able to see that that had historically happened. So this is a huge win to where that's no longer going to count against a practice. All right, there are no major changes to the 2025 PI measures, which is great because there were changes last year. And instead of going through each of these measures, because it is a lot and not every practice has to report on it. And if you're not familiar with some of this language or the workflows, it's just going to be too much for you. But one of the things that I like is this particular slide gives a nice snapshot. You see the headers, like the measure name, what the point values are, and then if there are exclusions available, what those are, and then the points would be shifted over to other measures in the category. And then there's PI attestation requirements. So you must accept each of those to earn a score. So it's the use of ONC certified EHR, that's that cert ID I was describing. And then you attest that you do not limit or restrict the interoperability or the usage of the cert or the EHR. And you're also attesting that you would be eligible for ONC direct review. And so that's the body that certifies the EHRs. They may do analysis and reach out to some practices. And so that's you would be attesting that you would comply with any requests that they have. And then you must attest yes to the 2025 high priority SAFER guides assessment, and then also complete a security risk analysis in 2025. Again, if you're not used to reporting on the PI category, a lot of this jargon is going to be brand new. But if you're a customer of ours, we do try to go over this with you. We have more details about each of these and our kickoff presentations as well that we share with our customers. All right, for information blocking disincentive. So there's disincentives for any healthcare providers that were found to have engaged in information blocking, which went into effect July 31st, 2024. Under the policy, the disincentives for MIPS are a 0 in the PI category. So say you're a large practice and you have to report MIPS, and maybe patients are trying to get access to their medical records and you're knowingly restricting access, or other clinicians are trying to get access to medical records for continuity of care and you're restricting access, and they're able to receive this information, then you would have that up for review. You could receive a 0 in the PI category and then be put also on the right-hand side on the wall of shame. So on it used to be called the ONC, the Assistant Secretary for Technology policy. It will list the practice, the address, the identified info blocking practices, and the applied disincentive. And CMS will not apply the disincentive if you do have PI category reweighted. So say you're a small practice, you would just go on the wall of shame. You wouldn't have PI at 0. However, if you wanted to report PI and say you are reported, then you would definitely not want to submit it because you submit it and you get a 0. In that case, it is much better. You just take whatever the other category weights are. But if you are a large practice, you of course would have to report PI and you would just get a 0. And then we do have a blog about that as well. It's a great blog, and if we haven't yet, we'll put it in chat, but I'm sure it's already in there. So for the security risk analysis, there's several ways that you can perform it. One is with us, so it's with expert-led assessments to give you peace of mind. You're available to bundle it with your MIPS services. And then we can also partner with you to complete your annual Safer Guide assessment, which saves more time. And then just let us know if you want to learn more. Also, we can connect you with our preferred partner, which is Abide. And then you can also complete it on your own through various ways, like your internal IT, existing SRA support, or an ONC free tool, which can be quite cumbersome from the things we've been hearing from practices, but technically it is available. All right, next category we're going to review is improvement activities. So this is a 90 consecutive day reporting minimum. You will no longer, so this is a change, it'll no longer be a points-based scoring system. Instead, it's going to require a specific number of activities to satisfy the improvement activity category. So over on the right, the standard requirement is to attest for two improvement activities. However, the exception to only have to report for one is they've maintained this rule where if you're considered a small practice, rural, non-patient facing, or health professional shortage area, or HPSA, this would be an official status that is listed in QPP tied to your practice for that particular MIPS performance year. So if you qualify for any of those, you would only have to report for one, regardless of whether you're a large practice or small. Same thing for MVP participants, which I mentioned earlier, but I know I shared a lot. But MVP participants, small or large, would only have to report for one measure. If you're, say, a small practice and you typically reported on, for example, the 24/7 patient access measure, we know that's a very popular one, that previously was considered a, quote, high weighted measure. So you were able to get those double bonus points by just reporting that because you were a small practice. So you only needed to report on one measure. So for many practices, this scoring change may not impact them. However, there were what used to be called medium weighted measures. And we have seen some small practices that did report on 2 medium weighted measures to get your points. That will be a change for them. There is no high versus medium anymore. So some practices will feel the impact, and others it'll just be kind of business as usual and no major changes. And then the improvement activity is worth 15% of your MIPS final score without any category reweighting. All right, changes for 2025. So it's an addition of 2 new improvement activity measures. Specifically, the one that I want to call out is in the removal where it says most common. And it's that very first one, the 24/7 patient access measure. That's the one I just mentioned before. We know that is a very common measure. Unfortunately, that measure has been removed from the MIPS program for 2025. We are working on making sure that we have clear recommendations for our practices now that that particular measure won't be available, since that was a very common measure. And then some of the measures, we even have some partners that we're working with to even streamline some measure implementations for you and not just say, hey, go figure it out. It's here's the measure details and here is a company or resource that we've vetted and feel like what could be a great fit for you. So we're working on doing that, and we'll have that ready for our practices for 2025. And then in a win, there are some improvement activity changes, but it's been delayed until 2026. So one is a modification of the IA measure, and that particular one is on implementation of patient portal. We have seen some practices report on this measure. This one didn't specify that it must be like a new workflow to implement portal, they are changing that for 2026. So in 2026, the rule is going to be that it must be a new portal by clinicians who were not previously using a patient portal. So if you were reporting this measure because you've been maintaining your portal workflow and enabling them and you have a good process, you can continue to report on this in 2025, but you're going to need to find an alternate measure in 2026. And then there's the removal of 4 existing IA measures that are going to be coming next year. We typically see the first 2 that can sometimes be used. Closing the referral loop. So that one will go away. That is not the same as quality closing the referral loop. It's always nice that they have the exact same name for 2 different categories, which is of course sarcasm. So the improvement activity closing the referral loop measure will be removed next year. And then timely communication of test results will also be removed. So those are things you're going to want to keep in mind for next year's reporting. And last, we're going to cover the cost category. All right, for cost basics, it's a full year performance period. The maximum points depend on which measures you're scored on, and each measure is scored out of 10 points. You're scored in real time, so we aren't going to know the score until the final scores are released. The cost category is weighted at 30% of your MIPS score. It is reweighted to the quality and PI categories if there's no measures that apply. And then if you're reporting through an APM entity or via an APP, then you wouldn't be scored on costs. Even if you qualify, you would just get that automatically reweighted, which can be great if you don't typically score well in costs. But if you typically score well, then it may not really impact or benefit you by having that reweight. And then for bonus points, you can receive up to a 1% improvement score for the entire category from the year prior if you've had an overall category improvement. If your category is just one measure, then it's just based on that one measure. And that's where you're going to know. It's similar to what I had said earlier when we were talking about quality, where you can get up to 6 bonus points for improvements. You may not know what that number is going to be, but you definitely know if there's an improvement. Same thing with cost. Once you may not necessarily know it clearly like quality, but say, for example, there's particular parameters that you're aware of about the cost measure. You've modified some workflows to help better set you up to potentially score better, or you've had some clinical changes in your practice. That's where you could anticipate that your score would likely be better. And then that's where you just know that you could score up to a 1% improvement if it has improved. There are many practices that may just say, I have no idea if it will improve. We might even say the same thing and agree, we don't know. And then it's a TBD, we have to wait till scores are released. But at least you know what it could be, that it could be up to 1%. And then you report the cost category through administrative claims, so it's no additional work, with the exception of some analysis and feedback that we are able to provide our practices. This is not any feedback that CMS provides. It is our own doing, where we have done cost analysis for practices to be able to give insight, score improvements if possible, and most importantly, to be able to advocate on behalf of practices with the academies and CMS to potentially create measure changes if we believe that scorings are inconsistent. As far as scoring go, which I just mentioned, so there has been a scoring methodology change, which is really exciting that they're actually going to apply it to the 2024 performance year. So it was in the 2025 rule, but they're going to retroactively apply it for this year, which is great. So the biggest thing to point out is that first bullet point with the highlighted blue one. CMS will set the median dollar amount for the performance year at 7.5 points instead of 5. So if typically you scored, for example, for melanoma, we've seen some practices score 1 or 2 points. At least we would anticipate or expect your score to go up some. It may not be a great score, but we felt like this was a huge, huge win with updating the scoring methodology. And then, oh, sorry, the remaining, just to call out the last bullet point, the remaining deciles will be determined by using the standard deviation from the median. It's just that the median is now going to be set to 7.5. And then for rulemaking process. So we have a strong regulatory presence within CMS and several academies, and we stay up to date with current and upcoming regulatory changes and advocate on behalf of our practices to improve and or change rules. So, and I've kind of mentioned that throughout, where we advocate on behalf for various things, including what I just mentioned about any cost scoring methodology issues. Some practices may score great in the melanoma measures, some do not. And so we've been advocating for those who have not been scoring well. But an example to also provide is that our policy staff were the first to recognize a particular diabetes cost measure group scoring methodology as a problem and advocated for this change in March of 2023. So we were the very first in the nation that caught this inconsistency. And we saw clinicians get picked up in the measure inappropriately. We were able to advocate to fix the scoring methodology. So if you're not familiar with this measure, that is as a result of us and our advocacy work that we did, because we did see many practices in 2023 scored. If you weren't scored, it could have eventually happened. It's just that you may not have been scored. So in 2023, we were able to file what's referred to as targeted reviews or contesting the score, and they immediately approved those to remove the measure attribution to those practices. And then starting in 2024, they just immediately, I'm sorry, for 2023, starting in 2023, they immediately just changed the rules. So we didn't have to start filing that anymore. So that was a huge win, and a lot of efforts were made once it was first discovered by our health policy team. And then each year, CMS releases a proposed rule for the upcoming MIPS calendar year. The public has 60 days to comment on it. That is our health policy team working very diligently to be able to have all of our excellent comments submitted. And then the comments are reviewed by CMS. The accepted changes will then be incorporated in the final rule and published by November each year, which is where this presentation is coming to you in December, because the rule was released last month.
All right. Finally, I just wanted to share a little bit about our strategy and how we help our MIPS clients through MIPS reporting. Since we do offer full service MIPS reporting with a dedicated MIPS expert from our team, we coordinate with your EHR and registry to help you through the process throughout the entire year. And that includes auditing your data throughout the year. And then at the end of the year, we do the submission for you. So sometimes we consider that similar to like a tax accountant, but for MIPS. So just wanted to give you an idea of how we are able to help support our clients if you do need additional support. All right, thank you guys for attending. Again, feel free to email us at mipsconnect@anatomyit.com.